So recording day 2 of the wrist and hand lecture. Yesterday we talked about the elbow complex and how the elbow has both flexion extension with range of motion. It also has pronation supination from the radial ulnar joint. We got down to the wrist and realized what a hot mess the wrist is with all kinds of tendons and ligaments and covering. And today we're going to start just finishing up the wrist. Then we're going to talk about the hand, which gets even more complicated. So with the wrist, right? Open packed position for the wrist. Again, in open packed position, what are we doing in open packed position? Open packed is for mobilization. Good. Closed packed is for the opposite, stabilization. Good, right? So open packed position of the wrist is neutral with slight ulnar deviation, right? Because remember, radiocarpal is the majority of the interactions between the actual wrist bones and the carpals. That most of it occurs over here at the radius. So if we slightly ulnar deviate, we open up that window a little bit that we can now slide the bones. Ironically enough, closed packed is an extension with ulnar deviation. Because in that extension, everything kind of locks in, all those tendons lock in, and you have that ulnar deviation. Now you cannot mobilize anything in the wrist. But in neutral, if I neutral and I radial deviate just slightly, I can shift my carpal bones all around. I can mobilize them up and down, right? I can mobilize them down. So it allows for that wrist to be mobilized. The capsular pattern, if you're facing a capsular pattern from all of those hot mess ligaments that are in the wrist, you'll have an equal loss of flexion and extension and minor losses in radial ulnar deviation. If your patient has full radial and ulnar deviation but is missing flexion or extension, then more than likely it's a muscular problem or a skeletal problem. If they've lost both equally, I just actually talked to, like I said, my PT friend that's a hand therapist was calling me because they've got she's got a patient that's got compartment syndrome of the hand. And sure enough, it's capsular pattern because the patient can only go up 5 degrees, can only go down 10 degrees, but has full radial and ulnar deviation. That means that that capsule of the hand is so swollen that you can't move it anywhere. So full range of motion of the wrist. Let's take off my watch here so I get full range. Flexion is 80, extension is 70. And you can actually see that a little bit, that if I turn my hand, you have a lot more flexion than you have extension, right? So let me ask you something. So when I go into extension, watch my fingers, okay? So pay attention to my fingers. What's happening to my fingers in extension? I'm not actively doing that. Why are they flexing? What's happening? What's causing it? Close. Think it over. There we go. Passive insufficiency of what? Just general. Passive insufficiency of what? Just, again, generalize the group. Of the finger what? My extensors are shortened. Yeah, the flexors. Right? So when I go back like that, my finger flexors are all lengthened out. Now, does that mean I can't get more range of motion? No, I can actually come up here. But look, as soon as I start doing that, what happens? My wrist starts pulling away, right? So as long as I'm in that full extension, right? And Erica, when you think about that, right, what's one of our key strikes look like? Well, why don't we strike with the open hand like that? Because, well, you can't. It doesn't work. Your wrist doesn't flex back. So when you go back, that allows, bending your fingers back to allow you to open up the palm for a palm strike. But when I go down, that doesn't happen because the extensors are actually a lot longer, and you've got a pulley system back here at Lister's tubercle that allows it to happen. So ulnar deviation, support my wrist, supposedly is 30. I think I've got closer to 45. I don't know what you guys think, but I think I got closer to 45. And radial deviation, we're supposed to have 20 degrees. There we go. I'm radially deviating. I honestly am. I'm going to try to put my thumb down and see if I can do it. Supposed to have 20 degrees. I think I have 5. But again, like I said before, right? Even if you look at my wrist flexion, I'm pretty confident I actually have almost more than 80 degrees of wrist flexion, right? But then when I come up, I definitely don't have a full 70 of extension. Yeah, maybe 3 degrees, right? And 3 degrees is the reasonable error in measurements. So are you sure you have 3 degrees, or are we just guessing? So here's some normal functions. To use a phone, you need about 0 degrees of flexion, about 42 degrees of extension. Right? If I'm holding my phone, you do need some extension in your hand to hold your phone. Open the door, 40 flexion, 45 extension, 32 ulnar deviation. Drinking out of a glass. Sit to stand, you do need extension, right? Because your hands are going to push. And when they talk sit to stand, this is what they're talking about, sit to stand. Because you can stand up without your hands. But as we get older, we need more and more of our hands to sit to stand. Eating with utensils are there. So the good news is, again, just like the functional motions of the elbow, it's very unlikely they're going to ask you the specific numbers here. But what you should realize is extension's probably the big thing that we need in that wrist. And what you're going to find throughout the whole body is the one thing we are focused on is extension, 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 extension. If I have an elbow fracture, focusing on extension. One of the things I'm going to focus on the neck, extension. One of the things I'm going to focus in the back, extension. If I have a knee replacement, extension. Hip, extension. The main reason is we can get flexion back later on down the road. But if you lose extension, it's really hard to get extension back in most of your joints. So landmarks, when you look at the hand, it gets really difficult to figure out where we're going to go. But let's take a look for flexion and extension. We're going to measure this on the lateral or the medial border of the hand. So we're going to have the person put their hand down on the table. What do you think is going to be our fulcrum? We're going up and down. What do you think a good fulcrum might be on that side of the wrist that allows you then to kind of go off of it? Styloid process, right? Styloid process is going to come back to haunt us quite frequently, honestly. Just because it's such a nice pointy process and it's easy to find, right? Okay, good. So what do you, hold on, I'm trying to see if I have the picture of this. Where did my chat go? I lost my chat. Oh, there's my chat. Okay. So then going up and down with that wrist, right? The stationary arm is going to line up with the lateral midline of the ulna, right? So you're just going to come down that ulna and find that midline of it. And then the last part at the motion arm is going to line up with the midline of, what is this out here? What digit? If you got a metatarsal in your hand, you got problems. Metacarpal, there we go, yeah. Remember, we walk on tar, we catch carps. That's the way I always remembered it, right? So your fulcrum itself is going to line up, most clinics will line it up with that lateral malleolus. In a true hand therapy clinic, they're going to line it up with the triquetrium. That gives you a better kind of point to go off of, right? And you're going to line it up with the major meat of that fifth metacarpal. You don't want to come all the way out here because the pinky is going to move on you, right? This is not going to move. Even when I come up into flexion, I've still got the metacarpal lined up. hold on a second. 350 is the final number. So you're going to line up with that and going to go into extension and go into flexion. So what you're going to have the patient do is, if this is the desk, right, you can either take a roll, you know, make a little towel roll and put it under the wrist to allow you to go into it. Or what I tend to do when I'm doing my measurements is I take the hand right to the edge of the desk so the hand is off the desk, because that allows them to go into flexion, allows them to go into extension really easy. So if that is gravity functional motion, what do you think against gravity is? How are you going to remove the gravity from the hand? What are you going to have them do? So this would be a case where we're not going to put them inside lying. What are we going to do to the forearm? Just turn it upright, right? 90 degrees. That allows us to eliminate gravity, right? And you're going to find, so according to the books, when you do extension, you do it here. When you do flexion, you turn it over and do it here. What you will find is most clinicians are just going to take the hand here and get both motions in one shot. Because again, with range of motion, although it's important to see if they can go against gravity, it's not as important as manual muscle testing. When we go to manual muscle testing, it is important. So just keeping at the edge of the table and getting my flexion, then getting my extension in one shot makes it a lot easier than having to mess with, well, is it with gravity? Is it not with gravity? Right? So it makes it just a little bit easier. So radial and ulnar deviation. We do have to measure that as well. So let me see if I can get there we go. I got a shot on my hand that way. With radial and ulnar deviation, the stationary arm is going to line up with the midline of the forearm. So what would be a good piece of soft tissue to line it up with that's in the midline of the forearm? What runs right down the midline of the forearm between the radius and ulna? The what? No, what tissue runs between them? Their interosseous membrane. Yeah, right? So you want to kind of line it up with that midline. Once you get it lined up, that's good. The membrane you can't spell. Interbone membrane. That's the way I always remembered it. Interosseous membrane. Between the bones. So your fulcrum is going to be your capitate. And do you remember what I said about the capitate? What is the capitate when it comes to the hand? The capitate means what? Because we talked about it with capitulum, head. It's the head of the hand. So what you're going to do is I want you to come down to your hand here and just kind of lay your fingers across all of your bones, right? Flex down. You should feel a bone pop up into your hand. If you go up, you can feel it nice, right? And just feel that bone kind of sliding in there. Do you feel one that's kind of roundish that keeps moving around in your hand? If you've done that, you found your capitate, right? If you go above, you can find another one above it, and that is your Lister's tubercle. We don't want to measure off that, although if your clinic measures off Lister's tubercle, you measure off Lister's tubercle. Some clinics do, but most of them use the capitate of the hand. So that's your fulcrum. Line up, right? And then your movement arm is going to line up with the dorsal midline of the third metacarpal, otherwise known as which finger? Yes, the bird, the middle finger, no, third, not fourth. The bird, the middle finger, C7 goes alone, whichever you want to call it, right? So you're going to line it up again with that metacarpal, right? Now, a lot of times if you're having trouble finding that metacarpal, which you shouldn't, you should be able to palpate right down on it. It's really easy. Have the patient open and close their fingers. It allows you to see the tendon that's going to pass over it, and you can follow that bone right there, right? Because we want to stay just below that CMC joint. And then you're going to have them radial deviate and ulnar deviate, right? mess you up. Manual muscle testing, again, for flexion, palm up into the hand, extension, up into the hand. Radial and ulnar, you can do this way where you put them in with gravity, but honestly, most of the time you're doing radial and ulnar because it's such a weak movement. You're not going to torture them by putting a lot of force. I will say, please be careful when doing manual muscle testing of the hand or the fingers, because it does not take a lot of force to move a hand, right? If I've got my hand here, I can break it even if I wanted to. You know, if I'm testing it, I want to get a nice steady force, 5, 4, 3, 2, 1, but I don't want to force the person into flexion, end up dislocating their wrist or being mean to them. Also, when you're doing manual muscle testing, if they've got something like carpal tunnel syndrome, ulnar tunnel syndrome, stuff like that, a lot of times when you do those manual muscle tests, it's going to flare their symptoms. And so you may have to say, okay, kind of work your hand out a little bit. All right, are you ready to do the other test? Let's do the other test. All right, work your hand out a little bit. Just because when they have those type of nerve symptoms, you got to be paying attention to it. All right, the hand. I got to give it to somebody. Man, the hand is great. And we're going to give patients a hand when we measure this. Get it? Ah, ah, ah. So down here, we've got our carpals, right? Let me get my little annotate up here. Down we have my carpals. Here we have our metacarpals, right? And then up here we have our phalanges or our rays. Sometimes certain clinicians will refer them as the fifth ray, the second ray, and they do the same thing at the foot where they'll call it the rays. The rays come off that metacarpal. So we have our proximal phalanges, rays, yes, like stingrays. They'll sometimes say the first ray. If somebody says that to you, if they say the first ray of the hand, they're talking about the thumb. If they say the first ray of the foot, they're talking about the big toe. It's an old school term that I haven't seen a lot lately, but sometimes you'll hear me say it, especially when we're doing girth measurements. I'll talk about measuring off the fifth ray of the foot, and it just happens because I'm so used to saying that. So we have 5 proximal phalanges, right? How many distal phalanges do we have? Oh, I tricked you. We have 5 distal phalanges, right? We have 4 middle phalanges. So that's one of the questions they could ask you on the board, because even though this is an IP joint, this is still a distal phalange. So you have the whole hand, you know, all the other fingers have distal phalanges as well, right? This is still considered a distal phalange. It's just the name of the joint is different, right? So we have our MCP, metacarpophalangeal. We have 1 IP joint, right? Then we have our PIPs, where we have 4 of them, and then we have our dips. So our pips and our dips. So this is where we kind of talk about the way things work, right? Motions of the thumb itself. You're going to find a lot of our bones of our hand kind of look like Pringles chips. That's the way I always remembered it. So motion of the thumb, we have carpal, metacarpal, we have flexion, extension, abduction, adduction. Pringles, now I'm hungry for them. And we have opposition and reposition. At the metacarpal phalangeal joint, we have extension and flexion. And at the interphalangeal joint, we have flexion and extension. So the thumb's got a bunch of motions. So here is officially, according to your book, the motions of the thumb. So if I'm holding my hand up like this, they're going to say, coming across is flexion, coming back is extension. Add and abduction. And opposition is when you go and touch the other thumb, pinky, right? When you get that rotational component going on. And reposition is coming out of it. So flexion is just here. When you get that rotational, it's opposition. But I'm going to warn you, I think I said this before, some books will call this flexion extension. but technically it's not. That is truly ab and adduction. When you look at the body position I'm in, that's ab and adduction. Flexion is going to come this way. Extension is going to go that way. Right? So just be aware. If that were if your PT or something says it differently, ask them what they mean. But in traditional anatomical sense, you always go back to anatomical position. So if I'm in anatomical position here, that's add because I'm adding to the body. So what do they mean by flexion? Well, so what they would say is some of the books say this is flexion extension. So just coming off the hand here. So basically that's opposition or lateral prehensile grip. So let's say that is flexion extension, whereas they'll say that, no, let me get my hand up here. They'll say this is ab and adduction. And then they don't even count opposition because they say that opposition is a combination of flexion and abduction of the thumb. But pretty much universally now we've gone to this, where if we put the hand out to the side, coming forward is flexion, going back is extension, adding to the hand is adduction, abducting away, and then opposition adds that rotational component where you're going to come down and touch the pinky. You can also oppose to every other finger, right? And actually when we do tendon glides, this is one of the activities we're going to do in the hand to do tendon glides. And we're actually going to do some tendon glides here in a little bit. At the fingers, the phalanges, we have CMC joint, we have accessory motion, meaning there's almost no motion going on at the carpal metacarpal joint. At the metacarpal phalangeal joint, oh, and that makes sense because we're back here, right? There's not, like, you can get some opposition, which is where you get that kind of that curving into the palm. At the metacarpal phalangeal joint, we're going to have flexion, extension, and hyperextension. And again, with the hand, this is flexion of the fingers. This is extension of the fingers. That is hyperextension of the fingers. Because technically, we're not really supposed to go above it. And like, my pinky's a great example of it. I've got quite a bit of hyperextension of my pinky when you actually do manual motion of it. Then we have ab and add, right? At that PIP and DIPs, we only have flexion extension, and we can isolate it. So if we have patients having problems with just PIP flexion, what we can do is we can put our finger right there, and they can work on it, right? You can also go out and get the DIP and work on it. One of the other things that works great is anything that sits nicely as a spot, you can use it. All right, there we go. They have cards for that. Almost dropped the phone. They have all kinds of ways you can do it. I've used a credit card, works well for that, or a license if you don't have something handy. I don't give my patients my credit cards. That's just dangerous. So here's the metacarpals, right? Here's the carpal metacarpal joint. And if you look at the way they interact, the trapezium is the only one that interacts with which finger? Good, the thumb, right? There is a small amount of interaction between the trapezium and your index finger, right? But your index finger primarily will articulate by the trapezoid. Your capitate is going to be your third finger. So if you're ever having trouble again finding that capitate, find that ring finger, come all the way back, and right there's your capitate again. The fourth and fifth, right, are really hammy. They articulate with the hamate. No? Okay, fine. I thought hammy was great. So here's MCP, metacarpal phalangeal joint, right? We have flexion where we make a fist. We have extension where we come back, right? Ab and adduction. Do you guys remember what muscles help us with ab and adduction? the group of muscles, the ones that are inside the hand. What are the muscles that are inside the hand called? Intrinsic muscles. There we go. Good, right? Whereas flexion and extension is primarily extrinsic muscles, primarily. So when we get out here, here's where we kind of go out, right? So we've got our metacarpals, proximal phalange, middle phalange, distal phalange, right? You can go the whole way out and feel all the way out to those bones. Ligaments. We got our flexor retinaculum, which we talked a little bit about. We got our Palmar carpal ligament, transverse carpal ligament, extensor retinaculum, and extensor expansion ligament, which we're going to talk about being the extensor hood here. So flexor retinaculum again. The flexor retinaculum is going to be on the palmar side and cover, what is this space here called that we call this commonly? This is our, it's also where we get that one disorder. It's the carpal tunnel, right? Good. So there's kind of our flexor retinaculum. We do have this transverse carpal ligament as well. That's there. This is kind of showing you why this area is so commonly injured. So let's look at this. Look at all the stuff going through that little carpal tunnel, right? So we got our flexus pollicis longus. We got our median nerve, which is bigger than that picture makes it out to be, right? We have our digitorum profundus and digitorum superficialis. And all of that's laying under this ligament, under that retinaculum. Right? And there are blood vessels that pass through here as well, right? There's, I believe, 1, 2, I want to say there's 3 or 4. I can't remember off the top of my head right now. But there's blood vessels that pass through there. Now, can you see why people get problems with that area? Just looking at all the stuff that's going through there, it makes sense. Now, let's think logically, like a surgeon, and let's excise that. Right? If we've learned anything, so busy highway is a great example, Erica, actually. It's fantastic. If we've learned nothing, what happens to traffic when we make the highways bigger? Does traffic improve? It should, theoretically. It never does, right? Yeah, the more cars take the freeway, exactly, right? So in this case, we cut that open and everything's going to expand. So you end up with the same problem you're at. So that doesn't mean that it's always not a problem. If you've got a flexor retinaculum that is stuck down, it may be beneficial to cut off. But that just makes me think, why? Why do we do it? So quick on nerve distribution of the hand. 1, 2, 3, median nerve. Part of 4, but sometimes not. 4, 5, ulnar nerve. So median, ulnar. So if you're getting tingling in your pinky ever, it's your ulnar nerve. If you're getting tingly in these fingers, it's your median nerve. Do you remember what I called these two meaty areas of your palm? So what's the meaty area right here by your thumb called? You remember? It's the Latin word for thumb. Your thenar eminence. You remember me saying that? Thumb bicep, yeah, right? Thenar eminence, right? Eminence being a hill. So you have your thumb hill, right? And then over here you have your hypothenar eminence by your pinky. That is your below thumb hill. So yep, I was going to type it for you. I was actually in the process of getting my annotate up. So over here, let me just draw first on it. So over here, this big meaty portion, and then this big meaty portion. Let's draw an arrow off of it. There we go. Not to be confused with the Thenar evanescence. So there's our Thenar eminence and our hypothenar eminence. And if you have problems, I'm going to see if you can, I don't know, let me see if I can get my hands close enough here. Let me bring these down. If you have problems with median nerve or ulnar nerve, okay. Can you see the difference, how much smaller this Thenar eminence is than the beefiness of this one over here? You see a slight difference? The left one's kind of sunk in. It's easier to see in real life. Less meaty, right? Well, no, this is because of the nerve damage in my left hand. One of the signs of nerve damage that will happen very commonly, whether it's at the neck or whether it's in the hands, that went too far high, is you'll get thenar or hypothenar wasting. And even my thenar eminence or hypothenar eminence are a little bit wasted away on that left hand. Just because that's a sign of nerve damage. It's a real common sign that we look for. The muscles in that area just kind of waste. There's not much we can do about it. But it's a good sign that we can look at. So thenar and hypothenar eminence. The extensor retinaculum is on extensor side, right? The back side. It holds tendons close to the wrist. Will prevent what's called bowstring, where things kind of pop off. It also keeps the backside of the carpal bones from separating. The other thing both those retinaculums create is a pulley system that allows more mechanical advantage for all those tendons. And then way out at the fingers, we got these things called the extensor hoods, right? The extensor hood and the extensor expansion, if you look at this, my gosh, this is complicated. So we've got our extensor digitorum coming out here that'll go all the way out here to our distal phalange, right? But our lumbrical muscles come in, our interosseous muscles come in, and they all meet in this area called the extensor hood. And all that is that's the area where everything kind of meets in. You can palpate a little bit of it if you come back towards your knuckle. The extensor hood, is that what you're asking about, Kelly? And we're going to talk about that in a second, actually. Trigger fingers on this side. It's actually a problem with binding down to the palmar fascia most times. We're going to talk about it in a second. Good question, though. A lot of times, patients will end up with what's called an extensor hood rupture. So if they have an extensor hood rupture and that hood ruptures, they're going to lose extension of the fingers, and the fingers will actually contract this way just naturally. It's not necessarily trigger finger at that point. It's just contracture. But if you look, that kind of looks like the girdle of the stomach, doesn't it? You have all those muscles meeting together to hold that whole finger up, which is actually kind of cool when you look at it, but it's very complicated, right? And if you look, that allows for the extensor to attach on each individual bone so that you can extend just, by block off finger, I can extend just that part of my finger. If I block off that, I can just extend that. But in general, the fingers move together, right? You can usually flex your fingers separately. It's really hard to just extend one part of it. When you start, if I want to extend just that middle phalange, I can't do it without extending the distal. They kind of work together because they're all bound together by that extensor hood. Here's kind of looking at it from a different angle, right? So we've got our extensor digitorum muscle, right? The extensor hood kind of covers over it, gives that tendon a nice long place to attach. And then look at this. All of these areas that you see where we've got kind of this circling, all of that is creating an area for a pulley system, right? And so here, that metacarpal phalangeal joint, right? So metacarpal phalangeal is another fancy way of saying your what? So metacarpal phalangeal is another way of saying your knuckle. Yes, right? So your extensor hood starts just beyond that. And if you have problems with that, a lot of times you're going to lose overall munching. That's good. I must be hungry. Motion of the extension of the fingers. So when looking at this down here, right, this is kind of what happens when we do this type of motion. That extensor hood allows us to do that and to do, what's this grip called again? Quack, quack, duck or lumbrical grip. Good. Oh, I didn't know I could do that. Okay, cool. So then we have our palmar arches. Gee, the palmar arches look very similar to other arches. Where do we see arches before? In the feet, right? And if you look at this, remember the foot has a proximal and distal arch? Well, if you look at it, the palm has a proximal distal arch, right? It allows us to have this nice open area that we can grab onto stuff and lift them up, right? It's kind of important that we do a lot of stuff with our hands. So we have our proximal carpal arch, we have our distal carpal arch. All of that allows us to form that nice little cup area here, right? Remember when you were a kid and you used to grab water like this and drink it, or maybe some of you still do? Well, thank the arches for that. If you didn't have the arches, you wouldn't be able to do that. Yep, it 100% is. Just like the foot is a little bit more flexible and neutral. It's like, wow, now it makes sense. Muscles of the hand. Well, we have our extrinsics first. Remember, our extrinsics start outside the hand. We have our flexor digitorum superficialis and our flexor digitorum profundus. What is the difference between the superficialis and the profundus? Profundus is more fun, okay? It's deeper, one's fun. This has to be a Dr. Johnson thing. I'm not familiar with this one. One's more fun, right? It depends upon where they do what. Oh, it's an Erica thing. It depends upon where they attach at, right? So the flexor digitorum superficialis, which is superficial, obviously, stops out at those middle phalanges. No, I like it. Your profundus is very profound. It allows you to go all the way out to the tips, right? It allows you to do red round. And then you have your flexor pollicis longus, which goes all the way out to the tip of the thumb, right? So when you got the profundus and longus, they go together. Oh, it's more fun. It goes all the way out. I like it. That works. That's a new one. I just always went, because when you sit like this, you're kind of thinking profoundly. Or maybe it's just me. So here's kind of what they look like when they get out here, right? So we have all these muscles coming all the way out. And again, if you look at this, if any of you do any type of cross stitch or anything like this, look at the way this stuff threads through, right? So here, where'd my little drawer go? Let's go to purple. I like purple. Here we have our profundus, which is deeper. And then at one point, the superficialis kind of wraps around it and goes to that middle phalanx, right? Could you see this area here being an area of problem? Yeah, right? That can be part of the area where you may get trigger finger, right? If that kind of binds down, the tip of your finger is going to kind of go like this, right? And you're going to get partial flexion. Or worse yet, every time you bend that part of the finger is just going to curl if it gets stuck. Yep, sorry. I thought I adjusted it. I just didn't want you to see my fat belly. Right? So you can see that it's really hard to just control that profundus, right? The profundus, because the profundus threads through the superficialis, right? When you pull the superficialis, profundus gets pulled. That allows us to have a very powerful grip. And then here's our extrinsics of the thumb and fingers. We have abductor, pollicis, longus. Gee, I wonder what abductor, pollicis, longus does. Gee, could it abduct the thumb? Right? Good news is most of the muscles of the hand kind of explain what they do, right? That's the one thing I always liked about the hand. When we got here, there's a lot of muscles, but man, most of them tell you exactly what they're going to do. Extensor, pollicis, longus, and brevis, well, they're going to extend the thumb, right? This is an area of the hand that gets very frequently irritated, right? How many parents do we have in here? I forget, we have like 4 or 5, right? Did any of you get mommy's thumb when you had your kid? From the kid pulling? Nope. Adrian had mommy's thumb. Okay. Right. This area, because of the way it's laid out, just look at this. You've got these tendons kind of here, but you also got all this retinaculum and all the bones right there. And you end up with a point of irritation right there. You're pain there now, right? Yeah, you've probably got a little bit of, yep. Yeah, that's where I was going next. Yeah, you probably have a little bit of APL slippage. And yes, you can get it from playing video games, right? And texting. Yeah, well, the reason why you get Thenar eminence pain is because when we're massaging, we're constantly doing this, right? And so when we're constantly doing massage in that, this area is constantly tightening up and getting stuck. But gaming does the same thing because gaming would kind of rest in that position. So here's some more extrinsic of the fingers. We have our extensor digitorum. There's inconclusive studies to show that cracking your knuckles is bad. It's an old wives' tale that you're going to develop arthritis by doing it. I mean, if you crack your knuckles, you crack your knuckles. I'm a habitual cracker, so and I can't say that I'm going to get arthritis from that or from the many times that I've broken my hand. I think the Fonz did have an abductor pollicis problem. He couldn't adduct his thumb. It's just like anything else. The cracking itself, all you're doing is gliding the bones on the bones and just making that sound there. I could see long term if you did that like every day, 5 to 15 times a day. Yeah, I could see that being bad. It's a grade 5 mode, right? But, if you do it every now and then, as long as your fingers are mobile, I don't see a major problem. If you're like person that just kind of gnarled up and you're cracking your fingers, yeah, it could probably be a problem. But definitely I don't think, again, the research out there doesn't say that it causes you arthritis. That maybe, because the elbow's not really supposed to crack too much. The elbow's not designed, right? Yeah, well, I mean, that's probably because you've got some adhesions in there. And most of the time, honestly, when you hear stuff at the elbow cracking, a lot of times it's tendons moving or some adhesion breaking up. The neck, you'll get that pop. That's bone on bone. But, I mean, there I got mine to pop. But I can tell you that was brachioradialis popping because I could feel exactly where it was. Again, looking at the extensor muscles, there's more complication here, right? Because when the extensors get down here, they bifurcate. What does bifurcate mean? Bifurcate is a fancy word for splitting off. Yeah, like they split, divide. So they come out here, and that way when you use your extensors and you're extending one of your fingers, they all kind of move together, right? And the only way you can't do that is if you control it. Right? It's really hard, but even if, try just extending your pinky without holding your fingers down once. So just here, it's really difficult, right? That ring finger comes up with it all the time. Well, it's because of these little breakoffs right here of the tendons. But another area that we can end up with problems. Here's the extensor indicus, right? Gee, it only extends one finger. I wonder what finger that is. And then we have the extensor digiti minimi. I always just love that muscle. I don't know why, but that muscle just makes me giggle and kind of laugh inside. Extensor digiti minimi. All right. Here we start getting into how they break down, right? They come in. Here's our extensor pollicis longus going out to the thumb. Here's our extensor digitorum, and there is a small piece of small hood that kind of keeps them in place there. Here's our digiti minimi, but even if you look, the extensor digitorum still goes out to this finger. It still goes out to the extensor indicis. So they split, but they're definitely clear divisions of that muscle. And they have different muscle bellies. So we talked about the thenar eminence. You do need to know for your boards the muscles that make up the thenar eminence. So you have FPL, APB, and OP. Right? So I always think that the thenar eminence is OP because it's got opponens pollicis. Right? I always heard that the way that I was taught this in school is you're hitchhiking to FAO Schwartz. But I don't think FAO Schwartz exists anymore. So that may not be as good of an answer. But back when I grew up, FAO Schwartz was a big toy store. So FAO, Flexor pollicis brevis, Abductor pollicis brevis, and opponens pollicis. The key thing that your questions on your board are going to ask you on this one is they'll tell you which one of these is not part of the thenar eminence. And most of the time, they're going to have an adductor or they'll have an extensor. At that point, you know that one's out. Or any muscle that doesn't include pollicis, because the thenar eminence is part of the thumb. The deep palm, we have our adductor pollicis, our dorsal and palmar interossei, and our lumbricals. Both the interossei and the lumbricals are intrinsic muscles of the hand, right? And you can even stimulate them a little bit, right? Even though I don't have sensation in this, what's that called? Which one's not part of the eminence? Anything extensor, right? Or adductor related. See, flexor and abductor. Does that make sense? So that's what they're going to ask you. They'll give you the, I guarantee the questions I've seen on this most of the time, please don't hold me to this, but have been, which of the following is not part of the thenar eminence? And you'll go down, they'll be like extensor pollicis longus. That's not part of it. That's going to be back here, right? So that can't be part of the palmar side. So again, what do we use this for? What is this called in babies? Palmar grasp reflex, right? Why do babies need this to be integrated? And this is a primitive reflex. I shouldn't have this bad a palmar grasp reflex. Right, so they would wrap stuff and also to help them pull themselves up. Right, so that as soon as they touch something, they get that kind of grasp reflex going. Which is the exact opposite of the plantar grasp reflex that we wanted to stop integrating, so they stopped grabbing with their toes. Hypothenar, we have our digiti minimi muscles. That's what the way I remembered that. Right, so when we get out to the hypothenar eminence, it's all our digiti minimis because that's the muscle or the finger that's out here. So we have our flexor digiti minimi, we have our abductor digiti minimi, and our opponens digiti minimi. So in this case, they may ask you what muscle does not make up the hypothenar eminence, and they're probably going to have something like flexor digitorum superficialis. Nope. Right? They may say the interossei. Nope. The only thing that makes up the hypothenar eminence are the minimis. So looking at this, here is our thenar eminence. Let's go blue this time. Right? Here is our hypothenar. Here is our thenar eminence. And again, you can see that's a pretty beefy area. That allows us to have areas that we can push off of and where we're not pushing directly on bone, right? And if you talk to older folks, it's an area they get sore a lot of times because those muscles have kind of wasted away. And again, like Tyler said, with massage or people that constantly hold their hands in flexion, it gets sore really quick because we're constantly doing this kind of opposition grip, right? And just doing that alone, my hand's already saying, I don't like you very much anymore. I had to correct it and be politically correct. So here's our hand muscles, right? And this is looking at hands versus other muscles. So this is looking at the hand versus the wrist muscles. Huzzah, moving on. Here's that sensory distribution, right? So on the Palmar side, we have median. And again, you can get half of this fourth finger. Most of the times I see that just considered ulnar. And then the radial nerve is just the back side of the hand out here kind of in this thumb area. It does come up here, but it's pretty rare that you're going to be testing up here. You're going to be testing that right here. Functional hand position, right? What kind of grip is this? Does anyone know? Well, actually, this is a Nicolas Cage grip, right? This is pincher grip. Good, right? Power grip is what we do when we grab stuff this way, right? This allows us to have a lot of function, you know, even when we're doing curls or something like that, allows us to have a nice grip and not lose stuff. We can test our power grip by getting progressively larger and larger items that challenge it. Here we have precision grasp, right? Or precision pincher grip. There's other grips that we have out there, right? So there's our pincher grasp. What kind of pinch is this? Does anyone know? How many fingers? This would be a 3-point pincher grip, right? We can go to a 4-point, but it doesn't always work that way, right? So 3-point pincher grip. I already mentioned, what's this grip on the side of your hand called? If you come down, so let me find it. Oh, I can use my thing here because we will test this on patients. Put a piece of paper or something in that thumb and hold it and pull. Try that with yourself if you've got a piece of paper or cloth laying around. It should not be that easy for me to do that, right? So if I do the other hand, it's not going anywhere. That is on the lateral aspect of my hand, and it is a prehensile grip, so lateral prehension. Has anyone seen therapists test that in the clinic? Right? Yeah, right? That tells if we've got some nerve damage in the hand. And obviously, well, mine's nerve damage in the arm, but I'm a great patient for examples. Where's pen? Here's pen. What is this grip called? Let me turn it down some before somebody yells at me. Okay, typically it's called pencil grip, right? Because pencils come before pens, right? But it has another name to it. It's called the 3-jaw chuck grip. So 3 jaws. Jaw 1, jaw 2, jaw 3. 3-jaw chuck grip. It's also known as the pencil grip or the writing grip. No, right? And I know. I'm just talking about, again, who is Chuck? Wasn't he in a TV show? Right? Chuck Norris doesn't need to do 3-jaw chuck grip because the pen holds him. So that's called 3-jaw chuck. And this can be a problem for who? Who has problems holding a pen like this? Specifically, those you parents. Right? Kids, right? How do they hold it? Right? Or they'll hold it like this, right? Three-jaw chuck on the left is a little different. Same idea, but there's a major problem. If any of those that are left-handed, right? What's the major problem we have when we write with pen? Yeah, it smears the page, right? Unless you kind of turn the page. I don't know if you guys have ever noticed, but yeah, right? I had too. When I write, because I am left-handed, but I now write right-handed because I can't control this hand anymore. But even when I write right-handed, my paper is completely turned as if I'm writing left-handed, just because that's the way my brain works now, right? But it's a really difficult grip to do, right? So if you pick up a pen right now and you pick it up in your dominant hand, you're usually able to go right to that pencil grip. When you put it in your non-dominant hand, it takes a little bit to think about how to get it right, because normally you have that nice little writer's lump that you can work off of. So common pathologies, wrist fractures. Again, wrist fractures are really common. What was the wrist fracture I told you guys about that may involve the scaphoid with the radius? What's that fracture called? Starts with the C. So common wrist fractures we have, right? We have our Colles fractures. We have our reverse Colles. We have our boxer's fracture. Those are our common wrist fractures that we get. A Colles fracture is a posterior displacement of the radius. So the bone is going to break that way. Guess what our reverse Colles is? Yep, anterior displacement, right? Our boxer's fractures are a fracture out here, and they're from missing a punch, right? So boxers and martial artists were supposed to strike with these two big old meaty knuckles right here, right? They form the actual kind of spear to our sword. But occasionally, especially with hooks, it's really common that you don't get that hand lined up perfectly, and instead you catch out here. And because of the slope of that outside, it's really common to fracture your wrist on that medial side. That's a boxer's fracture, right? We talked about that. We talked about scaphoid fractures, right? Scaphoids are from fooshes, right? And also you can end up with that Colles fracture from the foosh if it's bad enough. One day there was this guy named D. Corvain, and somebody came along and said, you know what, buddy? There's a disease out there with your name on it. And sure enough, there was a disease with D. Corvain's name on it. No? I thought it was funny. Okay, fine. You guys are a hard crowd. Right? So D. Corvain's. Has anyone had D. Corvain's before? I'm trying to find a good picture of it. So D. Corvain's is exactly kind of what we're talking about when we talk about some issues with, there we go. I found a good picture. Hold on a second. And bring up this picture because this is a really kind of nice picture of it. So it'll help make sense. I love it. That was a great example. Let me just bring up the picture because it helps. So this is what we were talking about with mommy's thumb or when you're getting games problem, right? So you have that retinaculum that covers it. Well, then those muscles swell and get inflamed, and there's not a lot of room for them to expand. Can everyone see this hand? Right? So if there's not a lot of room for that hand to, or those muscles to expand, they're going to swell into that space, and then they're going to swell out and swell in. And that's going to cause all kinds of inflamed tendonitis. For this, what do you think a good treatment for this is that you guys have encountered before? And for those of us that suffer from it, maybe from gaming, what could you do to that area? Ice massage. Yep. Ice it up, bro. That works really well. And actually, if you talk to a lot of pro gamers, because a lot of pro gamers suffer from this, a lot, they ice before they game. Especially somebody like me that's a predominantly, mouse and keyboard player. From holding my mouse like this, right? I'm in constant, and I've got my buttons on the side of my mouse that I use constantly. And I'm weird that I use all the fingers of my thumb when I'm holding a controller, right? Or all the fingers of my thumb, all the fingers of my hand. That was good. All the fingers of my thumb. I only have one. But that really gets inflamed with people, right? Yeah, claw grip, exactly. Yeah, that's not happening with me. So that's that one. Decurvains here. Back to my PowerPoint. Dupuytren's. You've seen a lot of Dupuytren's contractures commercials lately, haven't you? Has anyone seen those on TV? Who's advertising for Dupuytren's right now? Does anyone know? Has anyone seen it? No? Just mesothelioma? So John Elway has been advertising heavily for Dupuytren's contracture because he has a really, really, really bad case of Dupuytren's contracture. Now, this is not his hand, but this kind of shows you what it looks like with Dupuytren's contracture. So just like everything else, why do you think all of a sudden we're starting to show ads for Dupuytren's contracture? What do you think is triggering it? Why would there now suddenly be ads for it? Let me bring up this other picture, which kind of is a really good. Now, that's my phone. Okay, phone use is causing it. Guess what they've recently developed for it? Medication. They've developed an injection for it. So now that there's an injection for it, we're going to start advertising for it, right? In reality, what you should see is a hand therapist. So this is showing you kind of what happens, right? So they end up with a little nodule on the flexor side, right? That nodule will eventually start, can everyone see the pictures of this? Okay. That nodule will eventually start kind of binding down your flexor tendons. And overall, it'll start creating that flexor tendon to become fibrotic, right? And a lot of times it's this finger. And I don't exactly know the science behind it. And maybe I have to ask my hand therapist what the science is behind it. I just know what a Dupuytren's is. But for some reason, it's like this outside of the hand, right? And if you get a chance and you see the commercial where John Elway's in it, look at the way his hand is. What was John Elway? What sport did he play? Yeah, he's a football quarterback, right? For the Denver Broncos. No one really cares about them, but they did, they do exist. Just kidding. Ha ha ha. Think about that for a second. Holding the football. Right? Does that not set you up potentially? Same thing with pitchers, right? I can't do the pitcher grip because I'm just never good at throwing. Right? But same idea. It sets you up. Pitchers and quarterbacks are often set up for getting the Dupuytren's because of the way they constantly grasp things. Now, in the early stages, we can treat this. Right? In the early stages, we can get in. What do you think we're going to do on this? If it's early, Tyler will tell you, we're going to spend a lot of time doing that. What am I doing, Tyler? Strip it and cross friction it. Yep, right? We're going to tear at it. Try to get that nodule kind of broken up if we can. Later on, when we get to this point, we're going to need a little bit of help from science. So we can use stuff like ultrasound, right? We can do phonophoresis. Do you remember what phonophoresis is? Phonophoresis is the delivery of medication, right, via phono ultrasound. Good. Now, when it gets all the way out to this side out here, unfortunately, we can see them in therapy, but there's not a lot we're going to be able to do at that point. What do you think they're going to have to do? Surgery, right? Yeah. We have one faculty member over on main campus that has really, really bad Dupuytren's contractures. And you can see it, like, I brought him in one time, I asked him, and then he didn't like being the example anymore, so he won't come in anymore for me. But he's got a really, these two fingers are kind of down like this, and so when he's talking, his hand's kind of like this. It looks like he's flashing gang signs at you. Right? Yep. Because even grabbing the mouse, right? Even if you have a vertical mouse, right, it's not going to change. And even think about it, holding a controller, right? So I'm holding my good old Stadia controller here. Even holding a controller, when I'm holding the controller, those fingers down there, and I'm one of the weird people that play like this. I know. Yeah. So the difference here, Renee, is this is Dupuytren's. You're talking about trigger finger, and I think I've got trigger finger coming up next. So let me change back to that real quick, and because we're going to be cutting out of here shortly. There's the Colles fracture, Smith's, which is also the boxer fracture, which we already talked about. Carpal tunnel syndrome, we've explained that ad nauseum. I'm not going to go over that again. Here's trigger finger. I knew I had a picture of trigger finger coming up, right? So trigger finger itself is just a small nodule developing in there, but it's not binding down. That nodule is just a swelling of usually that synovial joint. So if we have swelling, we can give a cortisone injections, which is what the enzyme they gave him was a cortisone injection. And that cortisone injection will calm down the swelling. Most of the time, the trigger finger will turn. With Dupuytren's, it's a fibrous nodule that develops there. And there's nothing that they can give enzyme and it's not going to break it up. The only way they're going to break that up is by cutting that fibrous nodule out. But again, you saw how complex the hand is. It's really, really common for them to go in for that Dupuytren's release and then to come out like this, because they might have bumped the nerve or cut a tendon. Skier's thumb. We actually had a student in one of our cohorts end up with this. He was skiing and ended up getting the pole stuck in a rock as he was going down. Yeah, it's like you hit a curb while driving. Exactly. They still call it skier's thumb. It's just like tennis elbow. Even if you break your thumb when you're doing driving, same idea. They'll call it skier's thumb. There's Dupuytren's. It's the exact same formation. Picture. It's great. All right. How many more slides do I have here? I think I only have 2, right? Let me see. Get down here. Oh, hey. Well, that was not what I wanted to do. Just finish that out real quick, and then we'll cut you guys loose. Not that. Stop share. Gosh darn it. The technical geeky guy can't get this right. There we go. Now I got it up. So open and closed pack of the hand are the fingers. Open pack is slightly in flexion, right? So just slight resting, what I call resting position. Closed is full extension. And thumb opposition is closed. So all the way across, rotated across. Obviously, I can't mobilize that thumb joint if I'm there. If I'm here in slight flexion, I can actually mobilize every single one of my joints. I can rotate them. I can pop them. Capsular patterns of the hands, all motions are lost, or fingers, all motions are lost. That kind of makes sense because all the tendons are stuck together. Range of motion of the thumb, right? CMC, abduction, 70 degrees, flexion, 15, 20 to 80 degrees of extension. MCP, we have flexion 50, 0 extension, going back out neutral. Some thumbs do have hyperextension if you've got a really messed up thumb. At that IP, 80 degrees of flexion, and you should be able to get an extra 20 degrees of extension, also known as hitchhiker's thumb. Fingers, right, at the MCP, metacarpal phalangeal joints are right here. We have 90 flexion, And we should have 45 extension, but I don't exactly think that. The PIP, we have 100 degrees of flexion. You can see it goes past 90. And then 0 is where we're at. We shouldn't have any extension, but some of us do have a little bit of it. Ooh, look at that. Isn't that cool? Yay. And then the DIP, we only get to 90, if you can get it. So there. Hi, how you doing? I'm doing well. How about you? Okay, am I the only one that talks to my fingers? Sorry. Functional range of motion averages. This is kind of looking at the different things. What I always say is with the flexion, you need about 60 degrees of motion for flexion in the hands. So that's ideally what the therapists are going to go for. And the reason they're going to go for that is there's this thing called tenodesis grip. Does anyone know what tenodesis grip is? Or tenodesis? So when a patient has a stroke and has lost their use of their hands, in order to get them to have some sort of functional grip, they will actually let the fingers contract and get to like this position here. So that what you can do then is by extending the wrist, you flex the fingertips. So they could literally put, come in, put their hand around something, extend the wrist, and have a grip. That's tenodesis grip. So you need about 60 degrees of flexion in order to have a tenodesis grip functionally. No man must touch any of the fingers. You guys aren't going to be hand therapists.